Laparoscopic adjustable gastric banding was a popular procedure at the end of the 20th century and the first years of the 21st century. In the last decades, there's been a shift in the treatment of morbid obesity from laparoscopic adjustable gastric banding to Roux-en-Y gastric bypass and sleeve gastrectomy. This surgical technique was mainly used in younger patients. One study, in which the opinion of the patients concerning the decision to select one technique was recorded, reported the ability of the band to be reversed, adjusted, and controlled as one of the main reasons for patients to choose this procedure over others. Surgical technique has changed from the perigastric technique as originally described to the pars flaccida technique. In the perigastric technique, the band was placed around the superior portion of the stomach by creating a retrogastric tunnel from the lesser to the greater curvature across the lesser sac. A 25 to 30 cubic centimeter gastric pouch remained. A high incidence of slippage, around 30%, and erosion, around 3%, were associated with this technique. The pars flaccida technique places the band high on the stomach, preserving the lesser sac and the posterior gastric attachments. This technique creates a 1 cm virtual gastric pouch and is associated with less slippage, less weight loss failure, and less chronic reflux. The three main long-term complications are band slippage. The gastric wall migrates upwards through the band. Its incidence is reported to be up to 22%. Symptoms are non-specific, such as abdominal pain, nausea, and vomiting. The most reliable test to diagnose band slippage is an upper gastrointestinal swallow. If the thigh angle, the angle between the longitudinal axis of the gastric band and the spine, is less than 4 degrees or more than 58 degrees, band slippage is diagnosed. It can be treated by removing the fluid in the subcutaneous port. If the slippage does not resolve with decompression, surgery is indicated. Band erosion. Reported to be as high as 11%, band erosion usually occurs in the first 2 years after the procedure. Patients can be asymptomatic or present with decreased restriction or epigastric pain, bleeding, port side infection, or intra-abdominal abscesses. Diagnosis is usually made by CT scan or upper endoscopy. Emergency surgery is seldom necessary. Gastric pouch or esophageal dilation. Reported to occur in about 11% of patients in the long term. The long-term outcomes of laparoscopic adjustable gastric banding have been reported by several groups as disappointing. Long-term failure rates have been reported to be as high as 40 to 50%, with an incidence of revisional surgery ranging from 20 to 40%. Economic analysis also shows the superior cost-effectiveness of Roux-en-Y gastric bypass over laparoscopic adjustable gastric banding.